So wrapping up the digestive system then. So we talked about the job of the mouth with the saliva, and amylase is to break down what? Break down starch. So digestion of starch begins in the mouth. Very good. In unison, that was really good. And then the stomach's job is to move it back and forth. What type of digestion do we call that, where we're moving food back and forth? What is it called? No. When we're moving parts back and forth, a generic term for that is mechanical digestion. Mechanical Right, that is a type of mechanical digestion. Segmentation is a type of, the general term is mechanical. Is it on the crossword? Yes, yeah, on Tuesday. So mechanical digestion, moving parts. And also, there's the other general type of digestion in the, no problem, is chemical digestion, and that's where enzymes are working on it. So if enzymes and chemicals are working on a food product, we call that chemical digestion. So the small intestine produces enzymes to break down food, and the stomach releases an enzyme hormone that acts on protein. So the stomach can digest protein. So chemical digestion does occur in the stomach with protein. And then amylase, we said, was the chemical digestion of starch up in the mouth. So anytime we have enzymes or chemicals, chemical digestion. So another secretion from the stomach that helps with breakdown is what? What'd you say? Gastrin is a hormone, yep, that acts on, it is released to the blood and acts on, promotes digestion, I should say. But the other, pepsin you mentioned, that's the one that acts on proteins from the stomach. But there's an acid in the stomach which helps break things down. And what's the name of that acid? Hydrochloric acid, yeah. So that's another example of chemical digestion in the stomach. And that can really cause lots of issues, right? Because when people have too much acid production, inappropriately, that can cause acid reflux, and that can actually burn the opening to the esophagus where the stomach and the esophagus meet and cause what we think is chest pain, but it's actually acid reflux. Yes?
What's the difference between acid reflux and GERD?
Same thing.
Okay.
Just a fancy name for, yeah, because it's called gastroesophageal reflux disease. So it's just the acids are refluxing from the stomach back up into the esophagus. So ways to treat GERD in patients or yourself is to avoid liquids at mealtime. Small sips of liquid. Don't have a big glugs of liquid, because that fills up the stomach and puts all that food right near that opening of the esophagus. Is after meals, don't lay flat. Keep the head of the bed elevated a little bit, or keep your patient sitting upright after meals for a while. Avoid triggering foods. Alcohol and coffee are bad for acid production. They actually cause spasms of the esophagus to cause it to open up a little bit and allow the contents to come up through. Obviously, eating small meals is important too, right? The holidays are classic for people to get acid reflux because they fill up on fatty, greasy foods that are hard to digest. And then just take an antacid, right? That's a helpful treatment. And some people that have chronic problems with acid reflux take a long-term medicine that doesn't just lower the acidity or raise the pH of the stomach contents. Like when you take Tums, you're just acting on it right there and bringing that pH up, fighting that acid, counteracting that acid. Some people take things like Prilosec. You've heard of that, right? What's the other one? Starts with a Z. Zantac? Is that the other one? Yeah. They'll take those medicines, and that actually acts on the stomach to slow the release of acid. So you have to take those medicines before you eat and take them on a regular basis, and it can really get you back to feeling normal and not having acid reflux so often. Yes? Yes, that's the generic version of Prilosec. Yep. That's the most commonly prescribed one, but recent evidence is out saying that it actually contributes to osteoporosis if you take omeprazole on a regular basis, especially in the elderly. So they're saying to not take that, look to switch to some of the other alternatives. So it's one of those things, right? We think we found the great cure-all, and then there's a side effect. So That's why you got to always be informed, and lucky we have people that are, researching these medicines and doing long-term studies. So anyway, so when you think of the small intestine, digestion and absorption, and what makes it specialized for digestion and absorption is these finger-like extensions that line the mucosa. Those are called villi. And then each cell, if you look up close here, I'll zoom in a little bit. If I zoom in on a villus, you can see there's simple columnar cells that line each villus. And each one of those also has microvilli, which are little extensions of the plasma membrane to increase surface area even more. So as food is passing by these finger-like extensions, you have all that surface area for absorption of nutrients and digestion. And some of those small little tiny, all those columnar cells carry enzymes inside of them. They produce enzymes, which are proteins, right? So they have a rough ER and ribosomes and a Golgi, and they're held in little vesicles. And when they're stimulated to secrete their enzyme, they act on that food and break it down. So we have, a lot of small intestinal surface area because of the villi, the microvilli, and then the length of the small intestine. It's like, what, 21 feet or something? I had that in your notes. So number one for digestion and absorption, but all the activity for digestion with the help of the accessory organs, the pancreas and the liver and the gallbladder, they secrete their contents right here at the top of the small intestine, the first part of it, which is called the duodenum. So that's the first section of the small intestine. And then the jejunum is just the middle portion where all that continued digestion and absorption can occur. So we want to keep things in the small intestine to allow that absorption. But now when people have gastric bypass, they remove the stomach, gastro refers to stomach, so they remove the stomach and they create a small pouch to act as a stomach, which is derived from the small intestine. So when they eat, they get full really fast because that small little pouch, doesn't hold a lot of food. But that digestion and absorption can occur, but they also remove parts of the small intestine. So when they eat, they need to make sure they eat really nutrient-dense food, and they take a multivitamin because there's less opportunity for absorption without having all that, intestinal tract still there. So they remove some of that. But what we know about the stomach and the small intestine, that it can stretch. The mucosa and the entire organ itself can stretch if we fill it a lot. So some people have had gastric bypass surgery, lost 100 pounds over a period of 6 months, and you look at them and it's like, oh my gosh, you're a totally different person, right? You look so different from not being overweight. But if they continue to have bad eating patterns and overfill that pouch, they can gain all that weight back. So they make sure that when people sign up for gastric bypass surgery, that they do counseling to make sure that they're making proper food choices so they're not going right back to where they were. Okay, so mucus just protects the lining of the stomach, and the small intestine and the large intestine. It's the number one secretion throughout the tract, is to make sure that the enzymes and the hydrochloric acid in the stomach don't digest the stomach wall itself. So mucus is a good protective layer. But as we age, mucus production goes down. So as mucus production goes down, that puts the elderly at risk for cancers and acids, damaging the inner walls. Ulcers are higher risk, and acid reflux is a bigger problem as we age. We're just not as efficient, at digestion. So some of the enzymes are named after what they break down. So remember peptide bonds are what hold amino acids together. So peptidases break down proteins, disaccharidases break down sugars. We know that the parasympathetic nervous system is what the rest and digest state is, correct? So when we stimulate the vagus nerve, which is the major nerve of the parasympathetic nervous system, that promotes digestion. So if you're constantly stressed, that does not promote digestion. So you eat a big meal, and then someone gives you some really bad news, or something really stressful happens, and all of a sudden, your stomach just feels sick all of a sudden, right? Or maybe even if you didn't eat recently, and someone gives you bad news, all of a sudden you feel like you're going to throw up, right? That is because of the blood flow when we're stressed is diverted away from the intestines and from the digestive tract to the heart and lungs and skeletal muscle. So people that have chronic stress end up having chronic acid reflux problems because the digestive process is impaired because of being in a chronic stress state. So that's why when we give people anti-anxiety medicines, they find that their constipation goes away, that they have a better appetite and they feel better just overall in the digestive tract because they've blocked that sympathetic response. And some people, get so upset, like in a divorce situation, they end up losing 20, 30, 40 pounds. I've talked to women, because in the 40s is when you see divorce, increase because kids are getting bigger. Couples are keeping, trying it, and then finally they hit the 40s and the kids are bigger and the stress levels are higher, and then that's when a lot of people divorce. So I'll look at them and they'll be down like 20, 30 pounds. I'm like, oh my gosh, you look great. And they're dating. Like, yeah, it's called the divorce diet because of the stress of the divorce, not just because they wanted to go out and date again. It's the stress of the divorce caused them to lose all that weight. So sometimes extreme stress can just shut down the desire to eat. But then on the other side of things, right, stress can cause us to want to eat as a way of comfort. So people gain weight when they're anxious and stressed, and other groups of people lose weight. Okay, so the liver then. The main digestive job, the liver has many functions, but the main digestive job is what? Bile production, yep. And we need bile to break down fats. So the key job of bile is to help us break down fat. So one thing nice about the liver is if it gets damaged, it can grow back. And it's a filtering organ, so it has a lot of other functions as well. It makes important proteins in our blood for clotting, and antibodies, and albumins, which are proteins that keep our blood pressure up. We'll talk about that more in advanced A&P. But a lot of the storage of sugar, fat, vitamins, copper, and iron. So we really need, our liver. You can't survive without your liver. It has a lot of functions. But the digestive function is bile production and breaking down those fats. So if we look at its helper, the gallbladder is tucked up underneath the liver, and it stores the bile. About 30% of the bile that's made by the liver is stored in the gallbladder. So when we eat a fatty meal, the gallbladder is stimulated to secrete its contents into the bile duct and put that into the duodenum and help break that fat down. Now, if we have a high-fat diet in combination with the hormone estrogen, we find that the gallbladder can develop gallstones, and then people need to get their gallbladder removed. So people at most risk for gallbladder and gallstones are women over the age of 40, women that have had lifelong obesity, and high-fat diets. So it's important that if it runs in your family, so you have a relative that had their gallbladder out and kind of fits those characteristics, that you recognize that the risk is, and you're female, and that your risk would be increased for that. But we can live without our gallbladder because it only stores 30% of the bile that the liver makes. So if the gallbladder is removed, people survive and do fine. But I asked someone once if they had any symptoms after having the gallbladder removed, and she told me that she finds that when she eats fattier foods, that it passes through her system a lot faster, and she gets kind of gassy and has to use the bathroom right away. So I don't know if that was just her experience, but it would make sense, right? Because you have a little less bile availability. So if you eat something fatty, it's not going to get broken down. And when the large intestine receives foods that should have been broken down, like if a person is lactose intolerant, they get gassy, cramping in the large intestine because those complex proteins that lactose was supposed to break down, or not lactose, lactase was supposed to break down, or that sugar, I should say, lactose is the sugar, is not broken down by the time it gets to the large intestine. It causes a lot of pain and discomfort. Like people that have colicky babies often find that those babies were lactose intolerant and they were being fed formula that had lactose in it. And when that hit the large intestine, caused a lot of gas and pain. So the pancreas is the other accessory organ, produces digestive enzymes. So we know that the endocrine function is to secrete insulin and glucagon for blood sugar control, but that's not the digestive function. Its digestive function is to secrete enzymes. So people that have cystic fibrosis, where they have too much mucus production throughout their body, have so much mucus production in that digestive tract that the enzymes from the pancreas can't penetrate the mucosal wall and digest those foods down. So as a result, when they eat a meal, they have to take a bunch of enzymes with their meal to break down that food. So the pancreas can't do its job very well because there's so much mucus in the system. So when people have pancreatic cancer, it spreads very quickly and it loses its function. So blood sugar control becomes a problem, digestion becomes a problem, you know, where those digestive enzymes are missing, so they lose weight very quickly and lose life. So the large intestine, its job as food enters from the ileum, from the last part of the small intestine, its job is to absorb excess water. So food and feces enters in here in the cecum, and then the appendix is right there. And the thought of the appendix is that it stores healthy bacteria to continue the food breakdown. So it sits in here, comes in as liquid, and as it moves by peristalsis, as it moves through the large intestine, water is absorbed out of it, so it's not going to be diarrhea. By the time it hits the sigmoid colon, it's solid, and water has been absorbed out of it. But what happens if the colon contracts prematurely when someone has the stomach flu? They lose all that liquid stool, right? And it leaves the body. So that stool, that liquid was meant to be reabsorbed and sent back to the blood, but instead it's in the toilet. So it's important that a person rehydrate if they have the diarrhea because of that water loss. That was meant to go back to the blood. And on the other side is if someone doesn't have a bowel movement for 3-4 days and that stool has been sitting in the sigmoid colon, that water absorption continues. So if you've got soft stool sitting in the sigmoid colon, but it's sitting there for 4 days, what's happening to it? You've got the peristalsis pushing it around, but it's not going out of the body. So what happens is the stool just rolls around in there until eventually it becomes hard, round balls from the movement in that end of the large intestine. And the biggest group of people that end up in the ER with constipation and impaction and huge issues are elderly women with dementia and young boys between the ages of 4 and 8. And did we talk about that in here already? No. What in my experience in having 3 boys that are 10 to 18 right now, is that the boy bathrooms in the elementary schools are not a friendly place to have a bowel movement. And maybe some of the guys can attest to the environment of the boys' bathrooms as kids are jumping over the top of the stall, harassing kids that are sitting in the bathroom that they don't want to go in there. I mean, am I right in the elementary school? Right. Right, yeah. Girls, though, I mean, girls go in the stall for everything, so nobody really judges when a girl goes in the stall. So girls are less, you know, prone to those issues than boys are. And I can't tell you the number of, I have one kid that had a constipation problem for that reason, and the number of mothers I've talked to that have been in the ER with their kids. One mother I talked to, her kid was so backed up, he was spitting stool. So, I mean, it's a continuous pipe. Like I said, we're a donut, right? So start at the mouth, end at the anus. If it's backed up, that works its way all the way up. And there have been people with intestinal blockages, like a tumor in the large intestine. That stool is not going to pass through, and by the time they come to the ER, they're also spitting stool. So it's a very serious situation when we block that piping system, right? So just think about colon cancer, though. Now, tumors bleed. Key thing with cancer is they grow blood vessels. So it's our own cells. So if person develops colon cancer, where do you think it is most commonly developed? What part of the large intestine do you think most commonly develops a tumor? Yeah, very good. Why did you say that?
Because as far as stool backs up.
Yeah, it sits there the longest. Yeah. So if you have a diet high in fat and preservatives, and that food sits there on the wall of that sigmoid colon for days and years and years and years, that's when we see tumors develop. And then, like I said, so the tumor is made up of cells of the large intestine, and then they grow capillaries to stay alive. They develop capillaries, and then those capillaries break very easily. They're very fragile capillaries. So when a person has a bowel movement that passes by that tumor, they see blood in the stool. And my experience of having 2 elderly female relatives die of colon cancer is they attribute the bleeding with a bowel movement as hemorrhoids. Because when you see bright red bleeding, you think, oh, my hemorrhoids are acting up again. But actually, it was colon cancer. So when we see patients come in with anemia, and then they tell you they have hemorrhoids, we think, oh, that doesn't sound right. You don't usually develop anemia with hemorrhoids. But if you have a bleeding tumor, you're going to develop anemia. And that's what happens to those people. And then there's also a blood test that screens specifically for colon cancer. So we've seen women come in the hospital with stage 4 colon cancer. And that means it's spread. And where it spreads to is the blood supply from the intestines, from the digestive tract, passes through the liver before it passes through the general supply, right? Because the liver, it detoxifies, what we eat, what we've absorbed into our blood. It passes through the liver and then everywhere else. So if we've got cells breaking off, entering the bloodstream, then that passes through the liver, and the liver develops those cells. Those cells are from the colon. So if we look at the tumors in the liver, those are colon tumors that have migrated to the liver and are growing there. And we need our liver. Like I said, we can't live without our liver, right? So that's what causes death in people with colon cancer stage 4 is the liver tumors. And sometimes they'll put radioactive seeds in the liver to kill those tumors, but it just buys them time. It doesn't cure the disease and allow them to, to live beyond 5 years. It's about 5 years when people have stage 4 colon cancer. So how do you avoid colon cancer? Well, it runs in families. So if it runs in your family, you're at risk. My husband runs in his family. His mother died of it, but she was 85. She had a high-fat diet, low sedentary, low amount of exercise. But that doesn't mean that she wasn't active. I mean, she was in the kitchen. She was one of those that if you threw something in the laundry basket, she would come and help when I had kids. If I threw something in the laundry basket, a half an hour later, it was folded and on the end of the bed again. So she was, my husband set the bar pretty high for me to be like his mother, and he learned very quickly that I did not measure up even close. He does the laundry, so what does that tell you? But anyway, you can be at risk for that. So it's something to pay attention to. People don't like to get a colonoscopy because it's uncomfortable. They give you a gallon of liquid that you have to drink in a short period of time. It makes you sick. I mean, it's just so much to take in. And then it causes watery diarrhea to literally, at the end of it, you're pooping water. I mean, it's pure water. Then we know a person is clean and ready to go in for their scope with the colonoscopy. Well, elderly women like my mother-in-law, who was very, prim and proper, the idea of someone putting a scope up her back end and looking in there is not something that she wanted to do. So a lot of elderly people don't get their colonoscopies. So if you have, it's holiday time, right? If you have relatives, older relatives that are over the age of 50 at least, ask them if you're comfortable. Have they had a colonoscopy? Everybody should be screened to make sure they're okay, because there are certain precancerous things that we discover and can treat, and then we know that those people need to be scanned more frequently, not scanned, scoped more frequently. So if you had a solid tumor here, you would notice bright red blood in the toilet. But what happens if you get a tumor over here? We do see ascending colon tumors. By the time it gets out well, first of all, what did we say the stool is on this side of the colon? It's liquid. So if it's liquid, it can get by a tumor easier, couldn't it, than if there was a tumor here and the stool is solid? So these tumors are detected less frequently because liquid stool can sneak by those tumors. And if they're bleeding, by the time it gets out and into the toilet, that's old blood, and old blood is black in color. So if a person goes to the bathroom, if you have a patient and you notice their stool is black, that should be a red flag looking for old blood. Or simply an iron pill. When we take iron supplements, that makes the stool black. Or Pepto-Bismol has a certain chemical in it, salicylates, I think, that cause the stool to be black. So those are benign, normal things. But anytime we see black stool, we have to look at intestinal bleeding somewhere along the way, old blood. Same thing when someone throws up, like a coffee ground, black, gritty-looking vomit, that is a sign of blood in the stomach, old blood in the stomach, and needs to be evaluated. Morgan, your face, I wish I could take a picture. Sounds gross, doesn't it? So, was it? Oh, okay. Hopefully that's all it was, right? So again, important to be screened. It's important that we go to the bathroom on a regular basis and not just say, well, I just struggle with constipation, that's just me. Well, again, having that stool sitting on the walls of the sigmoid colon longer than it should be is not good for overall colon health and colon cancer. So drinking water, if we need to keep our stool soft and keep it moving, we need to drink water. So if you struggle with constipation, up your water intake, double it, triple it until you get results. We know coffee stimulates the intestinal tract. Exercise definitely stimulates the digestive tract. So if you're sitting around, like in school, when you're sitting, studying, typing papers, that's not good for keeping things moving. So eating enough. Yeah. No, just stand up while you're studying. How about that? But anyway, so moving on then, mucus is really important, again, for just moving things through. So that's the number one secretion of the large intestine is mucus. And let's quickly talk about the reflex to have a bowel movement, because it's pretty interesting, I think, but I'm weird, so. First of all, when the stomach is stretched, if you look at number one, when the stomach is stretched, that sends a stimulus to the large intestine to contract. So when it's called the gastrocolic reflex. Gastro referring to stomach, colic referring to colon. So that there's a relationship between the two. When the stomach is stretched, those receptors stimulate peristalsis in the large intestine. And this is very active in people when they're young. So I would say maybe 35 and younger, maybe even a little younger than that, 30 and younger. So, what I find, and as a parent, some of you who are parents can relate to this, you're out at a nice restaurant, you're eating dinner, and the kids gobbled up their little macaroni and cheese and grapes, and you're enjoying the last part of your steak, and I gotta go potty. No, you can wait. No, I have to go poop. Oh. So now you leave your steak to go stand in the public bathroom and wipe a butt. So that's the gastrocolic reflex. It kicks in by the end of dinner time. And when maybe you remember yourself when you were a kid, you were pretty much leaving the dinner table and everybody's in line to go to the bathroom. As we age, that's less active. So grandma and grandpa and mom and dads, they can sit through the whole meal and not have to leave to go to the bathroom. But now the other one is the reflex that when mass movements occur that cause stretch of the rectum, that stimulates the urge to have a bowel movement, and that works in everybody. So when food moves from the sigmoid colon into the rectum and stretches those rectal walls, that's when a person feels the urge to have a bowel movement. So they reflexively constrict the external sphincter at the end of the anal canal to say, oh, I have to go, but not right now. I'm going to finish this, right? Finish whatever you're doing. Then that will continue, and it will continue, and it'll continue until a person suppresses it long enough that it goes away. And that's where constipation starts, right? Now that stool sits there, and then the bowel movement, tries to move again, and maybe you'll get another stretch. And if we keep suppressing, the colon stretches. And this is where the elderly, like I said, elderly women with dementia that aren't responding, to their reflexes, and maybe they're sitting for a long time, they're not moving, maybe they're not ambulatory anymore. Those are the ones, and they're on medicines maybe that cause constipation. That's where we see this impaction happen. But what happens is this part of the colon stretches. Now you have what's called a megacolon. How is a person going to, if a stool is this big, how is that going to fit through, a rectum that's half the size? It can't happen. So now we have to go up there and try to liquefy that stool by doing an enema. So we put a tube up there and try to break it up. Sometimes you can actually go in, and I've had to do that. It's probably the worst thing that all nurses don't look forward to doing is manually evacuating the bowel, the lower part, the rectum. But it gets results, so that's the good part. So anyway, so this is one of the problems when people have a child with constipation and they say, just get on the toilet and go, for goodness sake. If that reflex is not there, they can't just push it out. The rectum has to have muscular movements to move that food out. So they can't just go because you tell them to. But we do know that there's reflexes in the stomach on the contents of food in the stomach. Fatty foods stimulate bowel movements. And you may have noticed when you eat a fatty meal that you have a bowel movement pretty shortly after that. So we know that that does stimulate bowel movements in people of all ages. Do you have a comment, question? Mm-hmm. Mm. You feel stool when you go in there? Yeah, that's a sign that they need to be manually evacuated of that stool.
So you shouldn't really be putting
Right. No, yeah, exactly, and that happens. We have tried to put a suppository in someone and it's solid stool in there. That suppository is supposed to dissolve and irritate the lining of the bowel. Well, if it's stuck in the middle of a stool, it can't do its work. Yeah, and that's not going to happen. You go along the side wall, and then you...
The VM is actually in the rectum when you feel it.
It's in the anal canal and the first part of the rectum, yep. And when you put us up, and you're supposed to go all the way to your hand. Your full finger should be in there, and then the suppositories on the end of it. Of course, you lubricate with some, jelly, but yeah. So you have to scoop it out of there and then put it in. So yeah, it's not, an ideal situation, but it sure makes a difference in the comfort of your patient when you can get things moving. So as we age, what do we get to look forward to? Less, like I said, less mucus production. Because of that, the elderly are at more risk for infections and ulcers, cancers. Activity goes down, so slower peristalsis, constipation is an issue, absorption is less efficient. So do you ever notice your elderly relatives don't eat fresh salad? Or if you have a veggie tray of fresh fruits and veggies, they're less likely, fruits maybe a little bit more, but the veggies, the crunchy, hard veggies, they're less likely to take because that's harder to digest, and they end up getting diarrhea from that. So oftentimes you'll see less and less fresh vegetables being offered at nursing homes. What do you see at the nursing homes? All the vegetables are warm, canned, right? They don't offer. The cellulose that we can't digest, which makes roughage and helps like a normal digestive tract keep moving the food through, they can't break that cellulose, or they can't tolerate the cellulose, and it irritates that sensitive intestinal wall and causes diarrhea. Yeah. So canned or cooked frozen vegetables are easier on the gut for the elderly. Right, but if it causes, right, yeah, I mean, it's a catch-22, It's harder to chew, too, if people have dentures and things, it gets stuck in the dentures, it's harder to break down. But, the big thing is just giving people other sources of fiber. Strawberries are a good source of fiber. A lot of times you give people Miralax, that's their daily regimen is a glass of Miralax, or prune juice in the morning. That's a stimulant of the bowel. But because their taste and smell ability goes down, they're at risk for food poisoning. Because how do you know the milk went bad? You smell it, right? Or, heaven forbid, you taste it, right? You know it went bad. But if you've got numb taste buds because you're 85 and your nose doesn't smell as well, that's why the elderly like things that are really sweet and really salty, because their taste buds are bad. So as a result, they're at risk for eating rotten food. So it's important that, if you take care of elderly people in their home, take a look in their refrigerator and make sure they're not eating rotten food. And their eyesight is bad too. Like I bought some cheese at Festival Foods the other day, and we were running through the thing, and my son says, wait a minute, and he grabs the cheese and shows me there's all mold around the edges. And I was going to serve this to kids in elementary school during a health lesson. So, my gosh. If someone's allergic to penicillin, that can cause allergic reaction. So that would be very serious. So anyway, but it was just on the edges. So if I had really bad eyes, would I see that? Probably not. So we have to be careful. So if you have, again, elderly relatives, take a look in the refrigerator when you go visit grandma and make sure everything's up to snuff in there. So also, some people get little outpouchings of the large intestine, little stretchy spots of the large intestine that can get full of stool and burst and cause perforation of the bowel, just like a perforated appendix, and can cause death. So it's a very common condition, diverticulosis, and people that have it should be watched carefully for signs of a perforation. We have a relative who that happened to. He had no idea he had a burst colon, and he went to the doctor 3-4 times. He said, oh, it's just a stomach virus, you're fine, you're fine. Until all of a sudden he came in and said, I'm in such pain, and I've got the shakes so bad I can't stop shaking. So as he's sitting there, he's like, I feel like my belly's really swollen. As he's sitting there, his belly was just going like this over a period of maybe an hour. He looked like Santa Claus. By the time it was time for surgery, he literally looked like Santa Claus because his bowel had burst and was producing so much gas in his peritoneal cavity that it was just swollen and burst. So he had to have emergency surgery. They had to take out a large section of his bowel that had perforated, put a colostomy there, so where the bowel is connected to the outer wall, and the poop goes into a bag, the stool. And then luckily for him, 6 months later, after everything healed, they removed the colostomy, hooked the two ends back up again, and then he's a normal functioning bowel again. So lucky for him. But you know, if you don't know to look for those things, he did not know he had a perforated bowel. So we'll stop at that point. We'll pick up with the urinary system on Tuesday.